presentation regarding minimum data set coordinators. My name is Rachel. Thank you for taking the time to just listen. So I was always interested in becoming a MDS coordinator. I graduated in 2003. I became a unit manager of an Alzheimer's unit during that time. It was a locked 60-bed unit, and my MDS coordinator was so beneficial to my doing well at that time. For example, we would have someone with a catheter, and she would say, Rachel, do you know that they have a catheter, but we don't have the correct diagnosis? I was like, oh, no, I did not know. She would say, Rachel, do you know that we're utilizing this psychotropic medication, but we don't have an appropriate diagnosis? And I was like, no, I didn't know. And so I began to take notes and to call the doctors and take care of each little thing that she would say. At the time, by me being a new graduate and not having that much experience with long-term care nursing, I didn't realize that each of the things that she was bringing to me was things that would affect our quality measures and in some manner affect the way that the facility received their payment and the way that they were reimbursed. So as time has went on, I've become more familiar with it. But at the time, I was like, well, I love what you do. I love how you help me. I would love to help other people like that. How did I become an MDS coordinator? And she essentially gave me a vague answer, but it ended with, you need more nursing experience. You've only been graduated a year, so maybe give it some time, and then you can take a class, and then you can become certified. So time went on. I got into other things, went into other sections of nursing, and never did follow up on it till the past year or so. So this MDS coordinator presentation, I hope is very informative for you. So according to the Florida legislature, the scope of practice would be the same for all nurses, all registered nurses. Our scope of practice would not change. Being a professional nurse, we're expected to have substantial specialized knowledge, utilize that judgment and good nursing skills in everyday life as we take care of our residents, our patients, wherever we come across them. So you might say, who is these MDS people? What does MDS even stand for? So minimum data set is the acronym that represents, well, MDS is the acronym that represents minimum data set coordinators. They also can be known as resident assessment coordinators, nurse assessment coordinators. The MDS department works together, or they're part of the interdisciplinary team, and we all work together to input information into the resident assessment instrument to transmit to Medicaid, Medicare for reimbursement purposes. What do MDS coordinators do? I already told you a little bit of it. But as an MDS coordinator, you will perform interviews, you'll perform assessments on residents. On my slide, I have new residents, but you'll also take care and do interviews and assessments on long-term care residents also. Some people are in for short-term rehab. Some people are long-term residents. So everybody gets an assessment. Generally, the assessment falls quarterly, and then they're every 3 months. And then after every third quarterly, you have an annual assessment. Unless the resident experiences a significant change, and that change could be either good or bad. But if they experience a change, then we'll open up a significant change assessment, and at that point that'll reset how the calendar falls. From that assessment, then it'll proceed with quarterly assessments. Also, it is the duty of the MDS coordinator to schedule meetings with the interdisciplinary team, with the resident, with anybody that the resident wants to participate in their care, along with social services, activities, dietary, and rehab. Some of the other duties that I've spoken of is the preparation and timely transmittance of the electronic reports to the National Medicare and Medicaid database. We want to ensure the accuracy of medical records and coding procedures so that the facility may receive proper reimbursement. Because at the end of the day, everybody want to get paid. So you might wonder, so we're submitting things to Medicaid and Medicare for reimbursement. The thing that we're submitting is called the Resident Assessment Instrument, also known as RAI. The purposes of this assessment is for reimbursement. We also, which is very important, is how we keep the facility up and running, how we get paid, how we can take care of our families. But it's also a way to monitor the quality of care. It's also a way for the consumers to have access to nursing home information. So a way that you monitor quality of care through the RAI assessment is if the resident before was admitted to our facility with a stage 4, and now the wound has resolved. So that would show an improvement in their condition in that area, and so that is a way that we can monitor the quality of care. Likewise, if the resident came in with clear intact skin and then now they have a wound, then we want to know why. That has now triggered a negative quality measure, which may most likely affect our payment, the reimbursement that we receive for the care of that resident. And so you also want to look at, like, how can we prevent this? Like, what is going on with the resident that these things are happening? Are they eating well? Are they being turned and repositioned? Are they going to therapy? What is going on? We need to do further investigation. So it not only provides ways to monitor the quality of care, it opens up a dialogue to give the best care possible. So you've heard me say a couple of times now about the interdisciplinary team. And the interdisciplinary team, Blason Hayes defines as an interprofessional team that consists of all disciplines required to provide quality care to an individual client. So the interdisciplinary team, you think that as an MDS coordinator, that the MDS coordinator puts all the information in by themselves without any input from anybody else. But that's not how it works. The MDS coordinator utilizes the information that the nursing staff gives them, and then whatever doesn't flow into their assessment, we utilize a system called point-click care. So some of the information that they put in every day will just flow into that assessment, depending upon their assessment reference dates. So depending on the assessment reference date, whatever they put in during that time, that information will flow. Sometimes all of the information might not flow, and then you have to go get it. And then we also have the social services department. They're responsible for sections C, D, E, and Q. Those sections review cognition, mood, behaviors, and goal setting, such as discharge planning, What are they expecting from the care? Are they having any behaviors, anything going on with them um, that we need to discuss, review? Any changes of condition, anything. The activities department is responsible for one section that reviews the preference for customary routine and activities. And you would wonder, possibly, no, I would wonder, what about if the people can't talk? What does activities do? So if the resident cannot speak, then the activities department staff, they can interview their family, or they can interview the staff. And there's places so that they can indicate who they spoke with to obtain the information that they received. The dietary department, they are responsible for Section K. It looks at swallowing and nutritional status. The dietary department will put in the weights for the assessment reference dates. They'll put, are they receiving nutrition by mouth? Are they receiving enteral feedings? And then how much of that nutrition are they getting from enteral feedings? Should they be receiving enteral feedings? Also, some of the information that either social services or the dietary department can put in, it might trigger quality measures. So as the coordinator, you would want to go verify the information. You would say, listen, this triggered, this says that, okay, maybe we had them as a tube feeder before, and you don't have them listed as a tube feeder on this assessment. Is this information correct? Like, I see this order. Did you just miss it? And so it just opens up more dialogue. The nursing department is responsible for sections, for all the other sections that social services, activities, and dietary does not do. And Section A is the intake information. It just says the resident's name. Do they have Medicare and Medicaid? What are the numbers? Have they ever been married? Where did they come from? Where, if they're discharging, where are they going to? B section looks at their eyesight and their hearing. Then that's where we code that. G section looks at their activities of daily living. H looks at toileting. I look at diagnoses. J look at pain. L look at oral dental. M looks at the skin. N looks at medications. O, half of that O assessment is filled out by nursing, and the other half is filled out by the rehab department, should they be receiving rehab at that time. And the O section, you can code, is the resident having dialysis? Does the resident have oxygen? Is the resident a hospice patient? P section looks at restrictive devices. That would be any type of restraints. There will also be any Wonder Guards. Wonder Guards allow the residents to go and have freedom. However, because of the sound that the doors would make, that might inhibit them from proceeding out of the door unescorted, which is the desired effect, but it's also restrictive. So we have to look at the whole picture for that resident. V section is normally utilized on comprehensive assessments, and that reviews cause, and it looks at, for example, if the resident was on a psychotropic medication such as Seroquel, it'll say, it'll give you the opportunity to say if a gradual dose reduction had been attempted, if that benefit outweighed the risk for that resident, and what kind of signs and symptoms would we look for if there were any problems. Also, I didn't put up their S section. S section is a section that you can document any contact isolation. You can document if the resident had been out to the ER or out to the hospital. And you can, I can't think of the other things, but that's just a general overview of how the interdisciplinary team together with MDS coordinators, work together to fill out the RAI, so we can get that information to the state so that we can be reimbursed and everybody can get paid. So you've listened to me. I've been sort of drawn out, I'm sure, and you're wondering like, I'm a little bit interested in it. What kind of education do I need? So you can be a LPN, a licensed practical nurse. You can be a registered nurse. Preferably, they would like for you to have your certification through ANOC. ANOC is an acronym that represents the American Association of Nurse Assessment Coordinators. Um, and they have a national certification that just says it gives you a broader base to stand on as a MDS coordinator. It gives you more information so that you can make sound decisions during the coding process. What are the necessary skills as a coordinator? You need to be able to assess. You need to know that if on our G section that we had, and you remember I said that on our G section that sometimes it will flow. We utilize a documentation system called Point Click Care. So on Point Click Care, some of the information that staff inputs in that system will flow over to the MDS. So say for instance, we have a resident who utilizes a Hoyer lift, and that Hoyer lift is generally coded as a 4. That resident would be considered dependent. But for some reason, the CNA is coding the resident as a 2. It doesn't mean that we just leave it and say, oh, well, that's what they coded. No, we have to go verify the information. We have to say, well, I see an order for a Hoyer lift. Is this correct, or is the resident limited assistance if we're coding a 2? And we need to clarify, and then we need to document our findings. We need to be able to interview. Interviewing is a necessary skill. You not only interview the resident, for example, you'll go and ask the resident, can you see a small print? So you will actually hold up something for the resident to read, and you're going to verify, can they see that small print? And then if they can't, you give them a larger print and ask, can you see this? Can you read this for me? You can be cognizant that some people may not be able to read, and in that case, you can use shapes to identify what sizes they can see. And that is actually coded in our section B. So not only will you interview the resident, you will also interview your coworkers. For example, like if you need clarification on information, you also need to be able to type. Like, it's a lot of documentation. It's not necessary. They didn't say when I applied for my job, hey, can you type? But it's a good skill because it's a lot of assessments. It's a lot of information to put in, and it's good if you can, you got at least 50 words per minute under your belt. You need to have a little bit of detective skills because sometimes you have information, either it's not matching, or you might have information that just needs further elaboration. And then how do you elaborate? How do you find? Like, you gotta go and get it, gotta go dig for it. And that's okay because you're MDS, you're a nurse, period. Like, you got this. So another thing that would be a good and necessary skill is secretarial skills, because it's a lot of time management issues. You have to be able to schedule appointments. You need to send out care plan invitations to the resident and to the families. And then you have to be able to schedule meeting times for the ones that would like to participate in said invitations. So I hope you enjoyed my presentation today. That's the end. That's all I got, people. Have a